Good afternoon, everybody. This is Dr. Mohammad Faisal Khan. I'm the consultant neurologist at Houston Medical Collective. Welcome to our grand rounds. And today we have a very interesting topic of subarachnoid hemorrhage presented by Dr. Shimon Hope. He's a medical graduate from Poland, aspiring to become a neurosurgeon. And we are expecting great things from him. Hope we all enjoy his talk today. Welcome aboard.
Thank you, Dr. Khan. So, as Dr. Khan mentioned this presentation, I'm going to have the pleasure talking about subarachnoid hemorrhage, with especially focusing on the complications. But before that, I'm going to briefly go through characteristic and pathophysiology. So the plan for the presentation is actually we're going to do the background anatomy, epidemiology, etiology, presenting symptoms, some of the diagnostic steps and relevant scales, only in order to be able to focus on the pathophysiology that underlies the important and some of the complications that hopefully will be interesting for you. So let's begin with some short reminder on the subarachnoid space. So the subarachnoid space is confined between the, of course, arachnoid matter and pia mater, and between these two matters you can find very delicate portions of connective tissue, which are called arachnoid trabeculae. This is not the most important. The most important in the subarachnoid space are the vessels, so arteries and veins, but one has to also remember that we have cerebrospinal fluid inside, and the arachnoid granulations and villi which drain the cerebrospinal fluid. These structures are also formed by the arachnoid matter. So the subarachnoid space overlies the whole brain and also extends down to also overlie the spinal cord in the thecal sac. And the subarachnoid space is actually in the normal brain that doesn't have any hemorrhage. It's very tiny, especially above the gyri is very narrow, becomes slightly bigger above sulci, but at the base of the brain, where we have much more space, there are some portions filled with cerebrospinal fluid, and as this is at the base of the brain, we call them basilar cisterns. These cisterns are called after the structures that they lay in the neighborhood to. So the two biggest cisterns are quadriminal cistern and interpeduncular cistern, and we also can find prepontine cistern and cerebellomedullary cistern. So the other question I would like to answer is actually what portion of the arteries are confined in the subarachnoid space. So is it the whole intracranial vasculature that lays in the subarachnoid space? Of course no. So I'm going to follow the traditional division of the posterior and anterior circulation for the brain. And regarding the vertebrobasilar system, traditionally the vertebral artery is divided into 4 segments, and the V3, the third segment, it extends above the C1 vertebrae and the arch, and it becomes V4, which is called intradural segment. This is where it actually pierces the thecal sac and enters the subarachnoid space, because in the thecal sac on the outside we have the dura mater, which is adjacent to arachnoid matter. So the V4 is when it becomes subarachnoid. Regarding the anterior circulation, I'm also going to follow the most common division of the internal carotid artery, which is the one proposed by Boutilier et al. It divides internal carotid artery into 7 segments, and it's the C5 segment, also called clinoidal segment, which enters the subarachnoid space. But let me talk about the C4 segment first, as when you're localizing it on the angiograms, this is the most visible because of the shape. So the C4 cavernous segment, it's the one that forms the carotid siphon. It lays inside the cavernous sinus, so actually it lays between the two layers of dura. So it's intradural, because the venous sinuses of the brain are basically formed by two layers of dura mater spread and filled with blood. So after this C4 segment does his forward and upward bends, it pierces the roof of the dura and then the petrolingual ligament to enter the subarachnoid space, becoming C5. So pretty detailed, but I hope you will remember that since V4 and C5, the intracranial arteries become actually subarachnoid. So the next question is when they leave the subarachnoid space. And they actually stay in the subarachnoid space pretty long. So after they enter the subarachnoid space, they travel on the surface of the brain above the pile mater in the sulci, and they give terminal branches, become smaller and smaller, and before they dive into the cerebral parenchyma, that's when they pierce the arachnoid mater, and this is actually pretty interesting. So they pierce the arachnoid mater, but they leave the arachnoid mater, but they do not. They live in the Virchow-Robin spaces. So this might be called differently. So whenever they enter the brain parenchyma, this is where they leave the subarachnoid space, living in the perivascular spaces to feed the brain. So when we are considering subarachnoid hemorrhage, the first big division should be into traumatic and non-traumatic causes of subarachnoid hemorrhage. And if you look at the subarachnoid hemorrhage on CT, it's 90% chances it is a traumatic subarachnoid hemorrhage, as it's in the majority. And among these 90% of traumatic hemorrhages, to put it in a different way, 40 to 60 people with traumatic brain injury end up with subarachnoid hemorrhage. But more interesting from the point of view of neuroscience is the atraumatic subarachnoid hemorrhage. This is only 10%, but in this 10%, 80% is due to aneurysmal bleed. Further 5% is due to arteriovenous malformations. And there are other causes that I'm going to talk about briefly. Just let me mention before the important risk factors for aneurysmal subarachnoid bleed, which is hypertension, smoking, high alcohol intake, and also family history rises the risk of subarachnoid hemorrhage 2.5-fold. So as I was mentioning that I will talk about other than aneurysmal causes of subarachnoid hemorrhage. So let's talk about non-aneurysmal causes. In this division, it is good to consider it regarding the location. So if we have the subarachnoid hemorrhage in the middle of the brain, so in the perimesencephalic region, it's good to think that it happened due to a rupture of PCA. But if we see the subarachnoid hemorrhage at the convex of the brain, then we should ask ourselves, is the patient young or is he elderly? So in elderly, subarachnoid hemorrhage in the convexal region should be, the main differential should be cerebral amyloid angiopathy. In young people, it's RCVS. So now let's talk about the symptoms. So the classically described symptom of subarachnoid hemorrhage is sudden onset severe headache that reaches maximum severity at the onset, and this is also referred to thunderclap headache. And why is this actually a classical presentation, and what pathophysiology underlies it? So when there is a subarachnoid hemorrhage, there are two mechanisms that lead to sudden vasospasm. One is like in every other artery, when there's a rupture, there are intrinsic chemicals like serotonin that lead to the constriction. The second thing is, as you can even see here, the blood that extravasates from the aneurysm, it irritates and causes, basically irritates the artery, causes even more vasospasm, and this increased vasal tone, that's what is hurting so much at the presentation. And also, as I said, the blood is coming out into the subarachnoid space with the SAH, and it irritates not only the arteries, it also irritates and causes inflammation in most of the structures that lay in the subarachnoid space. So we should include in that also the meninges that overlie the roots of spinal cord. And this is very interesting because that's what we are testing doing the meningeal signs. So whenever there is subarachnoid hemorrhage, it causes inflammation around the spinal nerve roots, and any friction around the spinal nerve roots causes pain and muscular tension. That's why people have nuchal rigidity. That's why with Kernig sign they try to bend the other leg just to relieve the tension. So I find this very interesting. And also the other characteristic symptom of subarachnoid hemorrhage is photophobia. And it also has very interesting underlying pathophysiology. So the blood that enters the subarachnoid space also damages the ciliary ganglion, which provides the parasympathetic input into the retina. And as it is damaged, the retina tends to be bigger, so pupils are a bit bigger, letting more light inside, which leads to photophobia. So other classical symptoms which are connected with subarachnoid hemorrhage are focal deficits linked with ischemia or compression of the blood or aneurysm, altered mental status, seizures, but there is also a prodromal sign which can occur in the setting of SAH. So this is called sentinel or warning leak, and it has been shown that it occurs in as many as 30 to 50% of patients. So the symptoms are very similar, as there is a very small leak. We're talking about aneurysmal bleed right now. So again, there is very small leak which causes all the vasoconstriction and sudden headache, but it's a bit lower and shorter than the big hemorrhage. So this small leak is being quickly repaired with thrombus. And these patients experience sudden short headache. This small aneurysmal fenestration, let's call it that, is being repaired with a thrombus. When there is a thrombus, there must be a fibrinolysis. But in this case, already the arterial wall is very weak because of the aneurysm. And when the fibrinolysis kicks in again, it causes a big and major subarachnoid hemorrhage. So I think this is very important and interesting to remember that around even up to half of the patients are warned by this specific headache before they have the big hemorrhage. So now talking about the diagnostic steps in SAH, the first question we have to ask ourselves when we're suspecting it: do the patient's symptoms actually indicate subarachnoid hemorrhage? And whenever we are asking such a question, we should always look what is the EBM behind that. And this is where Ottawa SAH rule comes to play. This is a very strongly proven guideline. They have tested this guideline on 3,700 people, and it has been shown to have 100 sensitivity. So if we have a patient with any risk, high risk factors profile, like they had SAH previously or aneurysm, we should exclude them. All of these people need to be scanned. But if we have a patient with that we can suspect SAH, and it's over 15 years old, we just have to ask them these 6 questions. If answer to every of these questions is no, then we don't have to scan them. If the answer is yes, scan them. Sensitivity is 100%. So let's say we have a very high suspicion of subarachnoid hemorrhage, but we cannot visualize it on any imaging. Nowadays it is very rare because the imaging is very precise, but sometimes when it happens, we have to remember about 2 things and we can do 1 thing. So we can always do LP and look for fresh red blood cells, or for xanthochromia if it happened more than 12 hours ago. But it's also good to remember, especially if we're considering the convexal subarachnoid hemorrhage, that T2 and FLAIR modalities of MRI are much more sensitive than other modalities of imaging. So after we visualize and we are sure that there was a SAH, the next step is to localize the bleeding. And to do that, we can do CTA, we can do PSA, which is an angiography. It used to be a golden standard, but right now CTA and the MRA are interchangeable. I would also like to quickly talk about 3 scales that are commonly used in the setting of SAH. The first one is called WFNS. It's basically extended GCS score, and you only have to assess for the presence or absence of focal neurological deficits. It just helps to track the condition of the patient better. The second scale is also based on the patient's condition. It's called Hunt and Hess scale, and it helps to predict mortality in setting of SAH. So we have to assess the level of consciousness in the patient. Excuse me. And this scale helps to predict mortality, but indirectly it also indicates the likelihood of developing one of the complications I'll talk later, which is hydrocephalus, acute hydrocephalus, because in any grade above 3, it is indicated to put in the external ventricular drainage. And the last scale is not connected with patient's condition, it's purely radiological. And this is called modified Fisher scale. You only have to assess the thickness of the hemorrhage of the subarachnoid blood and determine whether there is blood in the ventricles or not. And based on that, you can predict the risk of vasospasm, which we'll talk about soon. So right now I would like to emphasize why I think that SAH is much more severe in its complications and more complex in its pathophysiology. And this is because, as we mentioned before, all of these structures that lay in the subarachnoid space, all these arteries, the arachnoid granulations, they're being impaired in functioning after any kind of big bleed into the subarachnoid space. Other hematomas like epidural or subdural hematoma, they are confined within the spaces from the surface of the brain and from all these arteries. Subarachnoid space, on the other hand, when there's a blood, it confines all the brain and spinal cords, so the consequences are much more global, and I will talk about that. So the most crippling and lethal complication of SAH is delayed cerebral ischemia. The spectrum of this complication is can be only radiographically seen, so only a vasospasm on the angiography like here. It can only be clinical finding without any angiographical finding. It it can be both, so you can see the focal neurological deficit in the patient and see it on the angio. It can lead to cerebral infarction and death. And this complication most commonly occurs between 3rd and 14th day after SAH, but can occur as long as up to 21 days post-SAH and peaks at after a week. And the statistics here are still very sad. So DCI affects 30% of patients, but among these 30%, another 30% die and 34% become severely disabled. So just to visualize it, let's imagine we have a patient with aneurysmal bleed. We saved this patient, and 20% of these patients will still die or be handicapped because of this complication. So this is why it's very important to monitor these patients in neuro ICU and assess for the vasospasm. The best imaging for this would be DSA, so again angiography. Not only because it's the most sensitive, but also it would allow for intervention. So it would allow for infusion of nicardipine, which is the calcium channel blocker, or angioplasty, which is much more effective for treatment of vasospasm. But on a daily basis in the neuro ICU, it is the transcranial Doppler that is being done on the patients, and the Lindegard ratio to assess for the vasospasm, which basically, as you can see, involves comparing MCA to ICA diameters. So how can we prevent from occurring of the vasospasm? So right now there are only two treatments, preventive measures to implement in the patients. One is nimodipine, which is again a calcium channel blocker, and it has to be administered within 96 hours after SAH. It actually doesn't prevent from vasospasm. It promotes dilation in the collateral vessels, arteries, so it's easier for them to supply the blood to ischemic regions affected by the vasospasm. And the other measure is just supportive treatment and maintaining normothermia, euvolemia, euglycemia, and avoiding anemia. I will talk about that here. So in the past it was a very big thing for the post-SAH patients to treat them with a triple H therapy, which stands for hypertensive, hypervolemic hemodilution. But in not recent, few years ago, the studies have shown that this treatment is much more risky than the benefits that it brings. So it's no longer advocated. It's the euvolemia, euglycemia, normothermia, just supportive treatment. And about the statins, 8 years ago there was a big study that proved there are no benefits on statins in the setting of prevention from the vasospasm. However, many clinicians, especially neurosurgeons, still advocate about administering these statins not to prevent from vasospasm, but to prevent from other chronic complications that I will talk about later. So, as we said before, we can expect acute hydrocephalus in any patient in a hand and head scale grading above 3. That's why it is suggested to put in the external ventricular drainage. So in acute setting, we should look for obstructive, non-communicating hydrocephalus, and that is because the blood just clots inside the ventricles and prevents the cerebrospinal flow. In the chronic setting, we should expect the communicating hydrocephalus, and that is because after some time, of course, the blood breakdown products, they impair arachnoid villi and the granulations, and they impair the absorption. That's how in the chronic setting, the communicating hydrocephalus appears, and this one is treated with EVD, and this one is treated with VP shunt, so ventricular peritoneal shunt. This is a Terson syndrome. It's also a complication of SAH. I think it would make a good neurosurgical e-pearl. This is the presence of preretinal blood in intraocularly in the setting of SAH, and this also happens very often. So in 25% of patients, this symptom occurs, and it is connected with worse prognosis. It is connected with worse prognosis because it's correlated directly with ICP. The higher ICP, the bigger likelihood for Terson syndrome, so for the preretinal bleed. Why does it happen? So in a normal human being, in healthy people, the fluid from the intraocular space is being drained by lymphatics. Lymphatics are the lymphatic system of the brain, and this is the only connection between the eye and subarachnoid space. So in healthy human, the intraocular space is higher than intracranial pressure. That's why it drains into the subarachnoid space. But if subarachnoid hemorrhage occurs, it elevates the intracranial pressure, and the blood is being pushed into the lymphatics, and it leaks into the ocular space. So Terson syndrome. After SAH, we can also encounter medical complications, and these that I have on this slide are connected, have shared the common pathophysiological pathway, which is the extremely high sympathetic activation. This occurs because the high ICP stimulates hypothalamus, and hypothalamus then triggers the sympathetic activation. So it can show us fever, as hyperglycemia, which is also dangerous because hyperglycemia above 140 again increase the risk of vasospasm. But also the catecholamine surge in hardened lungs can lead to neurogenic stress cardiomyopathy and neurogenic pulmonary edema. The treatment for the last two is supportive. For the hyperglycemia is the insulin infusion. Other two medical complications is the dilutional hyponatremia due to SIADH and cerebral salt wasting. Usually these two overlap. And the last complication that occurs in up to 36% of patients is anemia. And this is due to the blood loss from the hemorrhage and also phlebotomies. So anemia is not a risk factor for vasospasm. It's the blood transfusion. That's why the guidelines for transfusing blood in post-SAH patients are very conservative and only indicate to transfuse below 7 or below 10 if there's any ischemic symptoms like chest pain or anything like that. So now we will move to the creme de la creme of this presentation, hopefully, which is the chronic complications of SAH. And the first I want to talk about, the biggest one, I think, at least for me, was unknown, is the post-SAH syndrome. This is basically a dementia that happens after SAH. So we know that in ischemic strokes, it is pretty common to have dementia after that. But the hazard ratio in ischemic after ischemic stroke is 1.72 times general population. In SAH is 274, and 95% with SAH develop post-SAH syndrome. So it's almost everyone suffering after that. And if you ask how severely they suffer from this, it's 45% of patients after SAH cannot get back to their jobs. Organically, what it is observed in these people is the general atrophy of the brain, and especially in the temporomedial area, so the temporal and the places where the hippocampus is confined. So to try to at least a bit clarify the causes and pathophysiology of the post-SAH syndrome, I'll talk about three studies. All three studies were done on rats. These rats had artificially, of course, caused SAH. And in the first study, it was investigated what is the arteriolar reactivity in the brains of the rats after SAH. And the arteries were stimulated with adenosine, nitrous oxide, and also hypercapnia, which all should dilate the arteries. And what happened, there was only slight change in dimension. So almost no reactivity of the arteries after SAH, which means that the blood that extravasates on the small arteries impairs them, and what's worse, the lack of reactivity was irreversible. So basically the inflamed small arteries become stiff. That's the first mechanism. The second one is the researchers injected tracer into the basilar cistern of the rat's brain and just followed the CSF in the rats affected by SAH. And as you can clearly see, the CSF movement was severely restricted in the brains of the rats. It might seem like only an acute complication, as it's only 4 hours, but the biology in rats, this is translated on humans differently. It's probably the subacute setting for humans. The last study I want to talk about is the one where they tried to determine the level of oxygenation in the hippocampi of the rats after subarachnoid hemorrhage. Why hippocampi? Because they have one of the most sparse vasculature, which leave them more susceptible to ischemic injury. And what the researchers have found is in the resting state, in the hippocampi, the oxygen concentration was paradoxically too high, so it was hyperoxemic. But when there was stimulation put on the hippocampi, it led to, again, paradoxical drop of oxygenation. So paradoxical play of the arteriolar reactivity again. So all these three mechanisms, so impaired reactivity, which also leads to impaired oxygenation and blood supply, especially with higher demand with areas that are in higher demand of metabolism when they are stimulated, and restricted or impaired cerebrospinal fluid flow. All these three confirm that there is a organic underlying pathophysiology behind the post-SAH syndrome. So the last two chronic complications are the post-SAH chronic headaches that are daily in these patients and affect 30%, which also, I think, severely impairs their quality of life, and they, of course, can develop seizures. So for summary, as we are already all thinking in flowcharts, so the complications of subarachnoid hemorrhage, we should divide them into acute, subacute, and chronic. And acute would be the obstructive hydrocephalus, the interesting Thurston syndrome, and the medical complications, which we divide into the ones connected with surge of catecholamines and anemia and hyponatremia. Next, we go into subacute, the communicating hydrocephalus, and the most crippling and lethal complication, which is delayed cerebral ischemia. And into chronic complications, seizures, chronic headaches, and the most important for this presentation, post-SAH syndrome. Thank you.
Very well done. That was amazing. Thank you.